بسم الله الرحمن الرحيم. دكتور أحمد عبد الرحمن، أستاذ مساعد أمراض الدم قسم الباطنة. النهارده هنكمل الجزء الثاني من السي بي سي. احنا عندنا السي بي سي ده one of the tools of diagnosis of many hematological diseases and other diseases. It's one of the tools. It's not the only tool. So we have to depend on history and physical examination followed by investigations, and now we'll focus on CBC. Usually in hematology we have three cell lines: erythroid cell line, red blood cells; megakaryocytic cell line responsible for platelet production; white blood cell count responsible for white blood cell production. So when you are reading CBC, you have to consider these three cell lines. I'll start first by erythroid cell line. Erythroid cell line, red blood cells. The first parameter is hemoglobin level. And hemoglobin level, there is variation of hemoglobin level according to age and sex. So you have to consider the age and sex of the patient, and a normal range varies between males and females, between neonate, infant, adolescent, and adults. So according to hemoglobin level, we have three possibilities. In the normal range, normal. Decreased below normal means anemia, patient is anemic, or increased above normal, this means there is erythrocytosis or polycythemia. So according to hemoglobin, we have three possibilities: normal, anemic, or polycythemic. And hemoglobin level is the most practical and applicable parameter for to comment on anemia and polycythemia. Hematocrit representing the percentage of red blood cell to the whole blood, and again hematocrit with a normal range, normal, decreased anemia, increased polycythemia. But hematocrit affected by other factors, mainly fluid status. Patient is dehydrated or overhydrated. For example, if there is dehydration, loss of fluid due to diarrhea, burn, and so on, usually decrease in fluid, so it will be increased, concentrated, blood will be concentrated. On the other hand, if there is overhydration, excessive IV fluids, it will be diluted. So hematocrit affected by other factors. The third one to comment is red blood cells. Red blood cells usually average 5 million cells per microliter, and there is range. So according to red blood cell count decreased, this may occur in anemia, normal, or increased in case of polycythemia. So we have three parameters to comment on anemia or polycythemia: hemoglobin, hematocrit, and red blood cell count. But the most practical one is hemoglobin level. After commenting on anemia, you have to comment on indices, details, the size of the red blood cells, the concentration of hemoglobin within red blood cells. So MCV, main corpuscular volume, reflecting the size of red blood cells, usually measured in femtoliter. So according to MCV, we have three possibilities: normal range, this is normocytic; decreased below normal, this is microcytic; increased above normal, this is macrocytic. So according MCV, three: normocytic, macrocytic, microcytic. What is the value? This is important in narrowing the differential diagnosis of anemia. So if you, for example, if you have anemia, microcytic anemia, you have to consider certain causes like iron deficiency anemia, thalassemia, anemia of chronic disease, even sideroblastic anemia. On the other hand, macrocytic anemia, megaloblastic or non-megaloblastic anemia. So you have to consider MCV to narrow the differential diagnosis of anemia. Second parameter reflecting the concentration of hemoglobin, main corpuscular hemoglobin and the main corpuscular hemoglobin concentration, and according to these parameters, either within normal, normochromic, or decreased, usually hypochromic. So you can say it's macrocytic hypochromic anemia, or it's a normochromic according to. So this is known as indices: main corpuscular volume, main corpuscular hemoglobin, main corpuscular hemoglobin concentration. There is a parameter known as RDW, or red cell distribution width. This is automated measure reflecting variation in size of red blood cells and esocytosis. So the cells more variable in size, the RDW will be increased, while it's the same, it will be decreased or normal. So RDW reflecting variation in size of red blood cells. What is the significance? For example, if you have microcytic hypochromic anemia and RDW is increased, this is highly suggestive of iron deficiency anemia. There is normal cells before iron deficiency, normal in size, then after iron deficiency, cells will be decreased in size. So variation, some cells small, some cells normal, leading to increased RDW. On the other hand, in case of thalassemia, it's again microcytic hypochromic anemia, but either normal or even decreased. Why? Because this is inherited defect. All the cells are the same microcytic hypochromic, so RDW not increased, known as RDW. You have to consider reticulocytes. Reticulocytes are immature red blood cells, larger in size than mature red blood cells, staying in circulation for 1 day, then mature into the mature form of red blood cells. So reticulocytes reflecting the activity of the bone marrow to produce red blood cells. So if you have anemia and there is reticulocytosis, you have to consider hemolytic anemia, bleeding, or someone receiving tonics or vitamins. So anemia with reticulocytosis, meaning the bone marrow try to compensate in case of hemorrhage or hemolysis, or someone receiving tonics accelerating red blood cell production. On the other hand, if it's decreased or normal, this is meaning there is underproduction of the bone marrow. It's occur in case of aplastic anemia, for example, or deficiency of the nutrients like iron deficiency, vitamin B12 deficiency, folic acid deficiency, leading to decreased production, so retics will be decreased or even normal. So reticulocyte is very important in the differential diagnosis of anemia, and any anemic case you should ask for reticulocyte by name because it requires special stain. So ask by name, I need CBC and reticulocytes. And usually it's measured in percentage, usually 0.22% or in absolute number. More than 2%, this is meaning there's reticulocytosis. 0.22, this is the normal. Less than this is decreased reticulocytes. Again, please don't forget blood film. Blood film usually very important. Microscopic examination of red blood cells very important. Can facilitate the diagnosis of many disorders. For example, if you find spherocytes, these are red blood cells lacking a central pallor. This occurring in case of hereditary spherocytosis or autoimmune hemolytic anemia. Sickling of the cells, sickle cell anemia, or target cells occurring with thalassemia. So this is very important to do blood film. After commenting on the first cell line, erythroid, I will shift to the second cell line, megakaryocytic cell line, responsible for platelet production. A normal platelet count ranging from 150,000 up to 400,000 per microliter. This is a normal range. So according to platelet count, have three possibilities. Normal platelet count for normal range, and decreased below normal, this is thrombocytopenia, or increased above normal thrombocytosis or thrombocythemia according to platelet count. I have also comment on platelet volume MBV. This is the counterpart of MCV, that may be normal in size or increased or decreased. So according to MV, you can say there is, for example, thrombocytopenia decreased in size, microthrombocytopenia. Microthrombocytopenia occurring with certain inherited forms of thrombocytopenia. For example, Westcott-Aldrich syndrome. This is rare inherited disorder, for example. On the other hand, if it's large in size, known as macrothrombocytopenia, there is low platelet count, but it's large in size, occurring usually with ITB immune thrombocytopenia. This is the most common cause of thrombocytopenia worldwide. Again, please don't forget again blood film. Blood film in all cell lines, in erythroid, megakaryocytic, white blood cells, and so on. Platelet count, if for example you have what's known as pseudothrombocytopenia. In this situation, patient, for example, going for surgery, cholecystectomy, CBC was done routinely, revealed there is thrombocytopenia, low platelet count, but patient no bleeding history. It's accidentally discovered, so surgeon will refer to hematologist. So patient will come to you no bleeding history, there is no bleeding from any side, but platelet count is low. You have to do blood film. Blood film can differentiate true thrombocytopenia from artificial or pseudo-thrombocytopenia. If there is agglutination of platelet and blood film, it is pseudo-thrombocytopenia. So you can differentiate true from pseudo blood film. So blood film is very important. The third cell line, white blood cell count. The white blood cell count, usually the white cell count normal range from 4,000 up to 11,000 per microliter. This is a normal range. So according to this, there are three possibilities again. Normal white cell count, decreased, known as leukopenia, or increased, there is leukocytosis. So these are the three possibilities. Number one, normal, decreased leukopenia, increased leukocytosis. This is known as the total white cell count. But there is differential. Differential very important. Usually normal differential, there are granulocytes involving neutrophils, eosinophils, basophils, lymphocytes, and monocytes. This is a normal differential. The most abundant one, neutrophils, about 40-70% of the total white blood cell count, neutrophils. Followed by lymphocytes, about 20-40%. Followed by monocytes, about 2-10%. Followed by eosinophils, 1-5%. And basophils 0-2%. So the least abundant is basophils. It's a normal differential count. Differential very important. Again, blood film very important. You can find abnormal cells plus in peripheral blood film, so suggesting of acute leukemia. So blood film again very important in case of white blood cells. So in CBC, first you have to read CBC, comment on all cell lines, then you have to do interpretations according to the findings. Now I will give examples of CBCs I will discuss with you. I will start by this patient named Muhammad Sha'ban Hassan. This is male patient. Age not mentioned here. Hemoglobin 8.5. So there is anemia. And hematocrit 26%, again low. So red blood cell count 2 million, so there is definite anemia. I have to comment on indices. MCV 93 femtoliter. This is in the normal range, normal from 76 up to 96 femtoliter. This is normocytic anemia. Main corpuscular hemoglobin 29.9 in the normal range is normocytic normochromic anemia. RDW 17% increased because the normal 12-15%. So there is increased RDW. So there is normocytic normochromic anemia. Platelet count 143,000 per microliter. There is mild thrombocytopenia. White blood cell count shooting 271,000 per microliter. So there is leukocytosis. So there is normocytic normochromic anemia. There is mild thrombocytopenia. There is leukocytosis. I have to comment on the differential. In the differential, the most abundant is lymphocytes. 68% of white blood cells are lymphocytes, forming about 184,000. There is lymphocytosis. So in this case, there is normocytic anemia, mild thrombocytopenia, leukocytosis, with the most amount is lymphocytes. So most amount cells are lymphocytes. So there is lymphocytosis. So I have to consider maybe viral infections, but the shooting count highly suggestive of CLL, chronic lymphocytic leukemia. I have to confirm by immunophenotyping or flow cytometry on peripheral blood, certain CD, to confirm the diagnosis. This is one example. Another example, male patient named Muhammad Abdullah Abdul Ati, aged 36 years, hemoglobin 11.4, so there is mild anemia because the lower limit 13. Again, low red blood cell count and low hematocrit, so anemia. MCV 76.9. It's again lower limit but normal, but still normal. Normocytic, normochromic anemia. Platelet count 734,000. 734,000. So there is marked thrombocytosis. White blood cell count increase, there is leukocytosis. So there is mild anemia, normochromic, there is thrombocytosis, leukocytosis. Differential here, 62% neutrophils, there is neutrophilia, and the basophils, the 10% basophilia, and 2% eosinophils, there is eosinophilia. So there is immature cells, myelocytes, promyelo, and the plus 2%. So this case is highly suggestive of chronic myeloid leukemia, CML, because there is basophilia, neutrophilia, and you have to ask for Philadelphia chromosome, translocation 922, or BCR able to confirm a diagnosis of chronic myeloid leukemia. Another CBC I will comment. Another CBC, this is a male patient named Ramiz Syed Hassan, age not mentioned, the hemoglobin 7.2, there is anemia, MCV 93 was a normal range, normocytic, MCH normal, normocytic, normochromic anemia, platelet count 61,000, so there is thrombocytopenia, white cell count 504,000. So there is marked leukocytosis, and the differential count here plus 40%. So most of them are plus. So this is a case of acute leukemia. To confirm a diagnosis, I need bone marrow. The cutoff value to diagnose acute leukemia plus at least 20%. I have to do immunophenotyping to differentiate acute myeloid from acute lymphoblastic leukemia. So this is as regard this CBC. The last CBC here. This is a female patient named Fathia Ramadan al-Sayed, aged 45 years, hemoglobin 8 gram per deciliter, anemia, MCV microcytic, MCV 78 is a normal range, normocytic, MCH was a normal range, is normocytic, normochromic anemia. Platelet count 31,000, so there is thrombocytopenia. White blood cell count 1,470, so there is leukopenia, so there is pancytopenia. So pancytopenia, there is wide differential diagnosis, ranging from defects in the bone marrow or outside the bone marrow. Defect in the bone marrow like aplastic anemia, and you have to confirm by bone marrow biopsy or find the hypocellular or acellular bone marrow. Usually there is no organomegaly. Also there is bone marrow infiltration by lymphoma, leukemia, myelofibrosis, myelodysplastic syndrome, bone marrow failure, myelodysplastic syndrome. This is defect in the bone marrow itself, or causes outside the bone marrow like drugs, chemotherapy, or viral causes, many viruses, HIV, hepatitis C virus, and so on. Hypersplenism, if there is splenomegaly, and the bone marrow hypercellular, hypersplenism. Autoimmune like systemic lupus. This is may lead also radiotherapy, radiation therapy may lead to pancytopenia. So it was wide differential diagnosis. This is the last CBC. Thank you.